and we'll continue the rest of the session. And thank you and welcome everyone to today's session. It's a very interesting one. It's packed with a lot of things for us to understand. And thanks for everyone that has been here all through the session. So let me share my slide. So today, this is the fourth session of our training. And I'm so excited. I'm already nostalgic that it's going to finish in the next 3 or 4 weeks. That shows how much we have learned, how much I have learned, even being part of the planning session. So I want to use this chance to appreciate everyone that has been a part of this, every presenter, everybody that asked questions, everyone that has been attending all the sessions. And I think some people will have an award because not that they attend, they come very early. So I'm really excited to be part of this. And today's topic is on mind, body, spirit, connections in health. And I think this session really wraps up everything we want to know about whole person health. And I just want you to take your time, listen, take notes, and be ready to ask questions. And if there are questions, please put them in the chat room and we'll take them at the end of the sessions, the presenters. As an overview, we hope to make this to be within under 2 hours, 90 minutes if we can. So this is the general introduction. We'll quickly go into the presentations and then the next sessions continue. Please bear in mind at the end, we expect there will be a post and post-course evaluation, and there will be project presentations. Project design, and we encourage us to keep those in mind as we go along. Happy to also say that we have curated the best of the best in the globe to be part of this course. And we're really happy for the partners we've collaborated with all the presenters that have come from the East, West to enrich, add value to what we're doing to this course in whole person health. So please feel free to reach out. The previous sessions are on the web. At the site, so please go through, read through, listen again in order to acquaint ourselves with them. So as part of housekeeping, we're recording this session, so just keep your phone on silence so that distractions are avoided. Questions, please put them in the chat room, we'll review them. And then we just hope that we'll have a great session. As if you want to have a little bathroom break, please stand up and join us as we go along. So without further ado, I call on Professor Kenneth to introduce our speakers. Over to you, sir. Thank you.
Thank you so much, Dr. Gloria. I am truly excited to introduce our speakers today. We have 3 wonderful speakers who are joining us today to share with us their expertise in this field. And so I will go ahead and introduce all 3, and then we'll hand it over to them and so they can deliver their presentations. So I want to begin with Professor Tracy Balboni, who serves as Professor of Radiation Oncology at Harvard Medical School, precisely at the Brigham and Women's Hospital and Dana-Farber Cancer Institute. And she is dually boarded in radiation oncology and palliative care. She is the Vice Chair of Education for the Mass General Brigham Department of Radiation Oncology and Program Director for the Harvard Radiation Oncology Program. Dr. Balboni also co-directs the Initiative on Health, Spirituality, and Religion at Harvard University. She developed and led the supportive and palliative radiation oncology service at the Dana-Farber Brigham and Women's Cancer Center, a service that is dedicated to the needs of advanced cancer patients. Her primary research interests address the intersections of spirituality and practice of medicine, including the role of spirituality in illness. Her work also includes optimizing the quality of life of patients living with cancer, including advancing the management of bone metastases. She is a graduate of Stanford University, Harvard Medical School, and the Harvard School of Public Health. After Dr. Tracy Balboni is done with her presentation, we will listen to Dr. Michael Balboni, who is a pastor, theologian, and instructor at Harvard Medical School. He serves as a congregational minister in Boston and within an intentional Christian community of healthcare professionals. His work centers on theology of medicine and spiritual care. With Tracy Balboni, he co-authored Hostility to Hospitality and co-edited Spirituality and Religion Within the Culture of Medicine. And he has a forthcoming book. And the title of that book is Walking Lois Home, which explores living out the Christian call to love the sick and dying. And after Dr. Michael Balboni is done with this presentation, we will listen to our third presenter today, and he is Dr. Arthur Presley, who is Associate Professor of Religion and Psychology at Drew University. Professor Presley is a clergy leader, a consultant, a specialist in psychological oncology and psycho-oncology, dedicated to integrating faith, mental health, and whole person care. With expertise spanning psychology, pastoral ministry, and the psychological and emotional dimensions of serious illness, his work focuses on supporting individuals and families facing cancer and other life-challenging conditions, while addressing the behavioral, spiritual, and psychosocial aspects of healing. As a professor and consultant, Dr. Presley is known for translating complex psychological and theological insights into practical strategies that strengthen individuals, healthcare environments, faith communities, and organizations. His work reflects a deep commitment to compassionate care, ethical leadership, education, and helping others cultivate resilience, meaning making, and holistic well-being. So as you can see, we have three wonderful presenters today to help us think through this intersection of mind, body, spirit, and the ways in which we can develop better ways to care for one another. So I will hand it over now to Dr. Tracy Balboni.
Thank you so much for that very kind introduction, and thank you to the organizers for just creating this wonderful event and gathering. Greetings to everyone across the various places where you are. And I'm going to begin by sharing my screen. Okay. So as you may have gleaned from our last names, Michael and I are married and share 3 children, and so in light of that, and actually our partnership and marriage has been a way in which we've brought together our worlds of medicine and theology. So definitely these, as you all are, as was already expressed in the introduction, this is really an interdisciplinary forum, and understanding that providing whole person health requires being interdisciplinary. So certainly that's helped us to learn from one another, and certainly is an important starting place as far as integrating spirituality into whole person health. So I'm just going to provide a bit of a framework for what I'm going to be doing initially, and then I'm going to be turning it over to Michael. So first, I'm going to provide a brief historical backdrop over the relationship of spirituality and the practice of medicine. And I think it's important to start there so that we understand a bit of why we are where we are today. Next, we'll consider research as a tool for reintegrating spirituality into the practice of medicine. And then I'm going to turn it over to Michael, who's going to provide more theological reflections on these relationships and on this evidence. I do think it's important to begin with some definitions, just so we sort of have a sense of what we all are speaking about when we say words like spirituality. You may be familiar with this definition of spirituality from Christina Bocholsky and others as part of the International Consensus Conference on Spirituality and Palliative Care, where spirituality was named as a dynamic and intrinsic aspect of humanity. So it's something that they're arguing here that spirituality is a part of all of us. Certainly, it's going to manifest in very different ways across persons, cultures, etc. But it's also dynamic, like it changes throughout our lives. So I think it's important that that be named. It has to do with a number of entities, which they aim to then include here, including ultimate forms of meaning, purpose, a sense of transcendence. And then it also has to do with relationship. So relationship to even how one relates to oneself, also family, others, and of course, the significant or sacred. And oftentimes it's expressed through various frameworks like beliefs or values, traditions, and practices. Religion is considered to be a sort of very much related term, where it's a communal form of a spirituality that has ways in which, because as it's shared by a community, it has common practices, common beliefs, common values, etc. But there are some other important terms in addition to spirituality and religion, and in particular to the practice of caring for patients' spiritual needs, which, as it sounds, are needs related to a person's spirituality. And those can be just spiritual questions, or even frank concerns, the need for practices, and then even frank struggles. So it's a fairly broad term encompassing the ways in which there can be tensions or needs within the context of health and illness. And then finally, spiritual care is recognition of and attention to spirituality within healthcare. And as you might imagine, there's many ways in which spiritual care is, not in all settings, but in many settings, is not necessarily well integrated into the care of patients. So as I said, I'm going to begin with a little bit of a why we are where we are today in the practice of medicine by touching on this historical relationship. And just to sort of summarize it briefly, I'd say that, I'm sure even as you all reflect on sort of the backdrop of the practice of medicine, it largely came out of various religious communities. Or spiritual practices within, or frameworks within cultures. And because medicine was birthed out of those spiritualities, there was a way in which care would automatically kind of had some degree of attention to the spiritual components of illness. But over time, we're seeing kind of a separation within medicine of the physical from the spiritual. And as a result of that, there is a divorce of the spiritual from the practice of medicine. And I'm just going to kind of provide some ways, some evidences of that prior connection leading to now the disconnection. So for example, of course, we think of Greek and Roman times as one sort of important historical time frame within which key concepts grew within medicine. So, for example, Hippocrates is considered to be sort of a major figure in the history of medicine. He set forth, he was really the first to set forth the idea that health and illness were the result of material realities and not necessarily spiritual realities. And but it's important to note that the practice set forth by Hippocrates was very much set within the spirituality of that culture. And of course, in Greek and Roman times, there's the worship of Greek and Roman gods. In particular, to medicine was the worship of the god Asclepius. And so here you see the original Hippocratic Oath, which was actually recited in its original form in U.S. medical schools up until about the 1950s, and now it's been adopted. Most medical schools actually continue to have oaths, although the language has been shifted. But the original oath was sworn by Greek and Roman gods. So, for example, Apollo, who's the father of Asclepius, Hygeia and Panacea being Asclepius's daughters, and of course, Hygeia being the source of our word for hygiene. And so you can see this kind of connection to the spirituality of that culture, even within the language. And of course, that symbolism remains. So the rod of Asclepius is a ubiquitous symbol across the practice of medicine. It's quite, you just look up symbols for various organizations. I have the World Health Organization here, and you see the rod of Asclepius featured prominently within its symbol. So we see even vestiges of this heritage very much today. But then when we move into the Enlightenment and postmodernism, there's a shift in that sort of marrying of the spirituality of the culture with the practice of medicine, and some of that comes out of the growth of the philosophy of materialism, which is this idea that all that we understand about ourselves and about our world is obtained through the study of the material world. Of course, the study of the material world has led to wonderful advancements in our ability to intervene upon the material world. And that's through its application through the empirical method. But it becomes a more primary way of obtaining truths about ourselves within humanity. And then medicine really grows in its material focus in care as a result of this. But there are implications of, of course, there's many wonderful advancements that are made because of our understanding of the material world, and within medicine, the ability to understand disease, to intervene upon it, to cure disease. But then the relegation of kind of the more the other aspects of what it means to be human can result in sort of issues with how patients are cared for. And I think that's beautifully illustrated in this painting. This is John Collier's The Sentence of Death, where we see the young man looking right at us. And we know by the title of the painting what has happened. This young man has heard news of a terrible diagnosis. And when you look at the figure of the physician, it's notable that there's sort of a disconnection with this young man. And where is all of the connection? The connection is with the book on the table, there's a microscope, there's a sphygmometer, there's the stethoscope, etc. And just signifying how, there can be an absorption into the, again, wonderful knowledge and technologies that are available to us in the practice of medicine. But that absorption can lead to a disconnection with the human aspects of what it means to face a serious illness. And I would argue that this even kind of impacts how care is given. And of course, it looks different across different cultures and how resourced various medical institutions are as far as providing care. But this excerpt from a editorial in the 1990s by some of the early palliative care leaders I think is an example of the ways in which that focus on the material can lead to issues. So this is an editorial about the technicalization of death. Again, I would argue coming from this zeroing in on the material and a neglect of the human aspects of what it means to face illness. So I'll just read this to you. The experience with this patient is a disturbing illustration of care received by many terminally ill patients in U.S. hospitals. Despite repeated requests by this patient that they presented as part of the editorial, that he receive no further life-prolonging treatment and that he be allowed to return home to die, the patient underwent a lung biopsy, 3 CT studies, daily phlebotomies, insertion of multiple nasogastric tubes, as well as a gastrostomy tube. He was tied to a bed for 29 days so that he would not remove the intravenous lines or feeding tubes. And he spent the last month of his life in the hospital. So this is just an example of how you can see these are very well-intentioned clinicians, and yet they're missing the human elements of this person who is facing a terminal illness, and very much focusing in on sort of technical material interventions. And I think with the division of the spiritual from the material, there's a tendency towards these sorts of neglects, and even, as I would argue in this case, even leading to some dehumanization of the patients that we care for. I just want to take a moment to consider, I said that medicine really grew out of spiritual communities, and of course the first hospitals arose out of spiritual communities, and there has been some attempt to kind of describe, based on sort of historical findings, et cetera, what care looked like in these hospitals. Gunther Risi is a medical historian who wrote about the history of hospitals, and of course wrote about, with that history, the rise of hospitals within faith communities. And he writes this in regard to the death of someone within one of those spiritual communities, in this case, a monastery. And he writes, first, the dying person confessed and then received the sacrament of extreme unction from the cleric who had heard confession and had absolved him. The administration of holy oil occurred on the traditional places of the 5 senses, and the other bodily areas considered to be suffering. Some brethren remained with the dying inmate throughout the day and night, praying and reading from the scriptures by candlelight. The point of this vigil was to ensure proper passing. Nobody should be left to die alone. If death became imminent, the whole monastic community was summoned, and the monks congregated around the sick on both sides of the bed, alternately to pray and sing. So you can see within this, a very different picture than what was painted in that New England Journal of Medicine editorial that I read to you. In this case, this is a picture of embrace and of presence. Of course, we want all the technical tools that were alluded to in the New England Journal of Medicine article that we have today, to be able to intervene and relieve suffering and potentially even save this person's life. But at the same time, we also want the care for the embrace of the whole person. That's, I think, beautifully illustrated in this excerpt. And I would argue that this sort of care not only embraces the person who is suffering, but also is humanizing and embracing of the people caring for the sick. So that's kind of the backdrop on which I want to begin to consider some of the evidence regarding the role of spirituality within the practice of medicine, within patients who are facing serious illness, and then also within population health. And I'm just going to provide a brief overview here by focusing on a JAMA Special Communications report. And this is that article that was published back in 2022. So I'd refer you to it. I'm happy to send you a copy if you need a copy, which essentially takes the evidence from the year 2000, you see it alluded to here, January 2000 to April 2022, and does 2 systematic reviews. One, spirituality in serious illness, so all articles pertaining to spirituality and serious illness, And then the other is spirituality and population health. So two separate systematic reviews. Over 20,000 articles were assessed, and only those meeting rigor criteria were included. And after all of the most rigorous studies, which were over 700 of them across both serious illness and population health, after those were sort of summarized and tabulated, an expert panel, a Delphi panel, was assembled in order to basically digest those articles and define what are the key findings of these papers between the year 2000 and 2022. So digesting all the evidence, and then those evidence statements created by that Delphi panel were rated, and only the strongest, those deemed as supported by strong evidence, were listed within the article. And I'm just going to point them out to you here. So there's strong evidence behind that spirituality is important for most patients with serious illness. Spiritual needs are common. Spiritual care within medical care is frequently desired by patients. It can play a role in medical decision-making for patients. And then finally, unaddressed spiritual needs are associated with poor patient quality of life outcomes. Relatedly are some findings regarding how the medical system interfaces with patients with serious illness and their spirituality. So, for example, spiritual needs are frequently unaddressed by healthcare providers who are caring for those who are seriously ill. Spiritual care is infrequent in general within medical care. And then finally, when spiritual care is provided, it's associated with better end-of-life outcomes. So what I'm going to do now is just give you a few examples of the papers behind those evidence statements, because obviously there were over 700 of them. We couldn't go through all of them today. So I'm just going to give you a few examples. So the first is this study of cancer survivors, over 8,400 of them, in which they were asked, "My faith or spirituality has helped me through my cancer experience." And you can see about 70% indicated that agree with that statement quite a bit or very much. You can see it's there was some differences across various racial and ethnic groups, in this case, in the United States. Another example is the role that spirituality plays within the quality of life of patients who are facing illness. One key way in which spirituality functions is to provide sort of a framework for resilience in the midst of the stressors of illness. So it's oftentimes termed religious or spiritual coping through one's faith, and it actually buffers people's quality of life in the setting of the stressors of illness. And so that's illustrated in this study, in which over 1,800 seriously ill patients were asked, "What's most important to your quality of life as you face your serious illness?" These were patients who had serious illnesses and were near the end of their lives. And of those 44, these were the top two: being free from pain and being at peace with God. So a very spiritual construct, being at peace with God, rising to the fore as one of the most important issues that patients themselves understand as dictating their quality of life as they face their serious illness. So this is just one example of the studies that undergirded that evidence statement that spirituality plays a major role in the quality of life of patients. Next example is that of the frequency of spiritual needs. This is just one example. This has been done across cultural settings, et cetera, with very similar findings, although the types of spiritual needs can vary depending on the cultural context, as you might imagine. So this is a study done in New York City, over 700, because of the sort of the ethnic background of those within New York City, it's very diverse. These were all cancer outpatients, over 700 of them. Actually, nearly the majority were spiritual or not religious, so an interesting kind of cultural group or spiritual group. And this was a validated scale, the spiritual needs assessment for patients. And you can see, just looking at the spiritual needs items that are shown on the x-axis and then the frequency shown on the y-axis, that these are quite frequent across the board. And in fact, at least one spiritual need was reported by nearly 80% of patients. So just illustrating how frequent spiritual needs can be. And again, findings like that were seen and have been seen across many cultural settings. I mentioned also within the evidence statements that spirituality plays a role in medical decision making. This is one of those studies that would point to that. This is a prospective cohort study in which they looked at baseline religious coping. I mentioned to you before, that's a salient feature of how spirituality plays a role in among persons who are facing illness. And its prospective relationship to the types of care that patients are receiving at the end of life. And on the x-axis here, we have aggressive forms of end-of-life care. These are all patients who were, when they were enrolled, had incurable cancers. So this was being ventilated in the last week of life, resuscitated, and ultimately dying in an ICU. And you can see that those who at baseline exhibited high reliance upon their spiritual beliefs to cope with illness tended to receive greater aggressive care at the end of life. Of course, that raises a number of questions. Why would there be that sort of relationship? One hypothesis is kind of illustrated in this study, that it's religious beliefs that are operating in end-of-life care that might actually be dictating how medical decisions are being made. So, for example, this one of these sort of potential beliefs that was assessed in these nearly 300 advanced cancer patients included, I will accept every possible medical treatment because my faith tells me to do everything I can to stay alive longer. That's one example. Another is a belief that God could perform a miracle and cure me of my cancer. And anything in the shade of blue here is some degree of endorsement of the item. And you can see many of these, it's very common, and it's among the majority of patients that endorse that belief at least somewhat. And in fact, a large majority endorsed at least one item, and about nearly 2/3 endorsed 3 or more items, just illustrating the frequency of these beliefs. So that's spirituality in medical decision making. I now want to turn to an example of how spiritual care is associated with better quality of life. And in a moment, we'll turn toward medical outcomes in serious illness. So this is a study that examined whether or not patients were receiving spiritual care at baseline. And it was assessed in a number of ways. And actually, those ways are illustrated here in the x-axis. I'm just going to turn our attention over to this finding over here on the right, within the bar graph. And this is the patient reporting any form of spiritual care versus none. So the blue is having spiritual care present as part of your care reported at baseline. The orange is no spiritual care. The patient saying, I'm not receiving any spiritual care as part of my medical care. The y-axis here is quality of life at the end of life. And of course, higher numbers meaning better quality of life at the end of life. And these are adjusted analyses. And you can see that those who were receiving spiritual care actually were, it's actually assessed by a caregiver present with the patient in the last week of life. Those patients tended to have better quality of life at the end of life. Spiritual care is also associated with sort of a change in how patients are making their medical decisions. So, for example, spiritual support, high spiritual support from the medical team, patients receiving it tend to transition to hospice more frequently, receive less aggressive interventions, and have less ICU deaths. And the impact of that is actually largely seen in those high religious coping patients. Interestingly, spiritual support from religious communities is sort of an opposite finding, where those patients tend to receive less hospice, greater aggressive interventions, and are more likely to die in ICU settings. And the findings are stronger in high religious coping patients. Of course, again, here we wonder, well, why are we seeing these relationships? One could argue it's if a very religious patient or someone who's highly relying upon their spirituality to cope with illness is interfacing with a medical team that actually attends to that, they tend to transition more to comfort focused care, things like that in the setting of a terminal illness. Whereas those that aren't interfacing with a medical team that kind of connects with them spiritually, it tends to be the opposite direction. As part of the systematic review, there's two systematic reviews, one of spirituality and serious illness, which I've just kind of walked you through, including some examples from the literature. There's also spirituality and health outcomes. So healthy populations. I'm just for sake of time, we can't go into all of that literature. So I'm actually going to just summarize it pictorially here. The first is that there's very strong evidence, even with sort of our highest level of sort of rigor as far as the analyses in order to attempt to distill out the effect of being involved in spiritual communities on health. But it's very much those that are associated with religious communities that are highly involved in those communities tend to have lower mortality. And there's also even sort of a dose response relationship. The more involved you are, the greater impact it has on your health, and in particular to lower mortality. There's a number of mental health outcomes that also tend in the positive direction. So those highly involved in spiritual communities tend to have better quality of life, better life satisfaction, better mental health, less depressive symptoms, and then less suicide. And finally, there is findings regarding substance use. Those involved in highly involved in religious communities tend to have less smoking, alcohol, drugs, and that's particularly the case among adolescents. So a number of important findings, not only in the setting of serious illness, but also in the setting of healthy populations. And of course, there's a number of implications of these findings. In fact, for this particular paper, the Delphi panel went on to make recommendations regarding how this evidence should impact the practice of medicine. First, in serious illness, they recommended that we should be routinely incorporating spiritual care into the care of patients with serious illness. We need to be including spiritual care education as part of educating our interdisciplinary medical teams. And then finally, we need to be including specialty practitioners of spiritual care in our care of patients with serious illness. In regard to health outcomes for healthy populations, very sort of analogous findings, we need to be including under the understanding that religious communities actually play a very important role within community health and integrating that into our health interventions, which obviously can manifest in very different ways. And we need to be providing education. That's the second one here. And then finally, the importance of recognizing spirituality as a social factor associated with health. So essentially what we're doing is we're moving from this, we're attempting, if you'll remember the model that I set forth to you all at the beginning of my remarks, we're moving from a divided sort of physical from the spiritual to returning to integration within our care. And of course, how do we begin to do that? There's actually been a generalist specialist model that has been set forth, actually as part of that International Spiritual Care Consensus Conference, where we have our spiritual care professionals, for example, chaplains as our specialists, and those of us who aren't specifically trained acting as generalists, and a key piece of that being providing the integration of spiritual history taking as part of our assessment of patients. I've just provided one example question here. Excuse me. And I mentioned to you before that I believe that there's the potential way in which embracing and providing holistic care not only has the potential to be better for better outcomes for our patients, but also even for ourselves. There's this interesting finding among trainees within a U.S. hospital here affiliated with Yale, where they looked at, they assessed burnout with this Maslach's burnout inventory, which is a validated scale for assessing burnout, and looked at its relationship to a validated spirituality scale. And interestingly, spirituality was associated with sort of improvements across the three domains of burnout. So it was associated with a greater sense of professional achievement, less depersonalization, and finally, less emotional exhaustion. So just some ways that that this sort of integration may actually result not only in improvements in the care of our patients, but even in for clinicians themselves. So the hope is that we would move from that prior Collier painting that I mentioned to you before, with the physician very much removed and focused on the technical, to an image more like this classic image of leaning in to the experience of our patients, and in that way embracing not only patients and their families, but also ourselves. So in conclusion, spirituality has only more recently been disconnected from medicine, and that has important implications, certainly for our patients, but even, I think, also for caregivers of patients in our institutions. It plays a major role in patient well-being and in medical decision-making in the context of illness, and we also saw important implications for healthy populations. And we need to be making efforts to be integrating spiritual care within healthcare. So with that, I'm going to go ahead and turn it over to Michael. Michael, are you going to be sharing your screen?
Well, thank you, Tracy. I think Gloria, I don't know what's next, but you don't want me to go next, right? You have something else right now?
Yeah. Kenneth, go ahead.
Yes, please go ahead. Go ahead, Michael.
So I'm sorry, you do want me to go into the...
Yes.
Yep.
Okay.
Yes.
My misunderstanding. Thank you. All right, I'll share my screen. Just 1 second. And okay, are you seeing that?
Yes.
Thank you. Okay. All right. So wonderful to be with you all. Privilege and honor. I want to just continue some of the with this interdisciplinary approach in thinking about the care of the sick from an institutional and cultural perspective, from the lens of a theological perspective. Full disclosure, I am a Christian pastor, and I'll speak from that tradition. I understand that maybe some or a number of you may not come from the Christian tradition. I'm not sure. But I'd like to speak out of my tradition, understanding that you may not be in that one, and I welcome conversation and reflection from any perspective, and to see where we might find congruence and possible disagreement. So I think when we think about whole person care, we have to think about the patient clinician relationship, in that relationship having an important component in healing. And we also have to think about that relationship, the patient-clinician relationship, within the surrounding culture in the support of that relationship. And that's kind of where I want to go a little bit, where Tracy and I have written about forces of hostility that have been distorting the relationship between the patient and clinician, and ways of recovery, possible ways of recovery, at least especially drawing from theology as a way to kind of see the distortions and possibly point in a way forward. And let's see, advance my slide. There we go. So when we think about the patient-clinician relationship, what is it? What is the nature of that relationship? And one way that we can get at the nature is to look at the language that's being used. And this is especially coming out of, this would be language especially that we see in the United States, perhaps in other contexts as well. But when we think about the patient-clinician relationship, what is the language that's being used to describe the relationship? And I'd suggest to you that there are a couple of different ways which people within the English language are describing what's going on. They would talk about the doctor or the healthcare provider as a scientist, in which or the physician scientist, sometimes we'll hear that sort of language. And that is really a scientific lens in describing what the doctor is doing. And it also provides we'll sometimes hear, maybe not directly, but it's often implied, sometimes it's said directly, in which the patient is a case. The case in room number 2. And you can hear the patient is more being seen as an object of scientific review, and the physician is more acting as a neutral observer and applying techniques to bring healing. That's the scientific lens. We're also in the U.S. It's become more common to actually quite common to refer to those who are providing health as providers. And that's become, the last 10 years or so, I'm hearing that more and more as the common way of referring to what we're doing as doctors, as nurses. They're providers. And that's actually an economic term. And the implication of the interaction between patient and clinician is that it's a buyer-seller sort of relationship. Of course, we all know that finances play a major role within health. You can't provide medicine without it costing something, and it's in almost every context it's very expensive because it requires a lot of people and so on. But is the doctor-patient relationship primarily an economic one? Some language is suggesting that's where things are going. Less common, but still there, is more of a bureaucratic lens in which the doctor and nurses are professionals. It's more of the kind of relationship around the organization, certification, the expertise that comes from being recognized with license and so on. And it's more of the bureaucratic kind of perspective. And then finally, the older language that comes out of the Abrahamic traditions is patient and clinician. Patient being Latin for a sufferer, and clinician as being a term in which it can mean two things. The Greek term kline, where we get clinician, means bedside, so someone who's at the bed. It's more of a description of where the person is, or the verb form of kline is klino, and it means to bend or to bow down. And so when we look at this image, you see the physician bending or bowing down before the patient, and I'll come back to that. And the patient clinician kind of description or language is the language of hospitality. It's a guest host relationship in which that is the framing understanding of what's going on when a patient meets a clinician. It's a framework of hospitality, and that these are potential ways in which we've described the situation, the relationship when someone is sick and being cared for. I'd like to suggest to you that within the patient-clinician relationship, there are 4 major social forces that are always at play, that have been at play. And there's been a shift in the 20th century. There's been a significant shift on how these social forces are shaping the nature of the healing relationship between the patient and those who are caring for the patient. And that shift has moved from a more personal relationship, which I would suggest to you is really important as part of healing, to a more impersonal direction. And that shift is, marked by the arrows growing of these impersonal social forces, the science and technology, the economic market forces that are shaping medicine. Again, I'm speaking especially within the West and especially within the United States, and as well as legal and bureaucratic forces, and that these invisible social forces shape what medicine is, how it functions every day. It's the culture that shapes what's going on in the care of patients. And within this, hospitality and compassion have always been a driving motivation. The care of the sick person. But as things have been shifting within institutions and cultures, it has been shifting and changing even the motivations within the caregivers, in which they absorb these different identities of being a scientist or having power or getting wealthy, and it can enter into the heart. And these impersonal social forces have tended to squeeze out the important component of the healing relationship that exists between patient and those who are caring for the person. So I'd like just to, when you hear host guest, that might sound strange to your ears. Like, is that really how I should primarily understand the nature of being sick and those who care for the ones who are sick? And of course, that is the from the deep tradition of from Judaism, Christianity, and Islam. It was especially Christianity that mapped on this kind of language of host guest, in which we talk about hospitals. Of course, a hospital is a place where hospitality is particularly received. So you can hear it in the language. And of course, that within the U.S., it's been interesting to watch that many places are leaving behind the language of hospital for medical center or other kinds of language that are medicalizing what the institution is rather than calling it a place of hospitality, because our culture is losing the sense of what that means. But I like to suggest that it's actually quite important to whole person care. You have to understand what the institution is and what the underlying interactions are. Hospitality is a collective practice in which the ill stranger is in need and is graciously received. You go to the hospital and there's strangers, just like if you were to go to someone's home, that's not your home, you're a foreigner. Oftentimes the language to be sick is to be a foreigner and in a dangerous place. And traditionally, when you were traveling, you'd go to a town or a city, and you didn't have a place to stay, and someone would take you into their home. And when you get brought into their home, they're kind of implicitly saying, "I'm going to take care of you. I'm going to protect you. I'm going to provide for you, and this is a safe place for you, and you will be well cared for." It's a covenant that exists between a host and a guest. And medicine that's really what's going on within medicine. The medical providers, the clinicians, they're strangers. There's not a personal relationship outside of this host-guest understanding. But within that, the doctors, the nurses, they have knowledge and a mastery of the technology. They're familiar with these things, and they're welcoming the guest who is on a dangerous journey of illness. And there is a power differential that exists between the clinicians and the patients. The clinicians have all the power, and what they're saying is, we're going to use our power to protect you, to help you, and to get you to the place where you want to go. And I think it's important to understand that within the healing relationship, it's not just about science. It's the relationship. It's the unique human relationship that exists between a nurse and a patient, and the doctor and the patient, and that healing is mediated in part through the relationship itself. And we're seeing that relationship again being distorted because of various impersonal social forces that have been taking place and growing within the U.S. and beyond. Within the Christian tradition, the language of hospitality is embedded And specifically in Matthew 25, it's also seen here in Luke 10, in which Jesus teaches the disciples that when you receive the sick, he says that you're doing it to me. And it's very, Christians have reflected on Jesus's teaching and have come to realize that there's something incredibly important about the receiving of the sick person, which is to receive Jesus himself. In the Apostle Paul, and this is really interesting, in Galatians 4, he says to the Galatian church that he had a bodily ailment, he was sick, and he said that my condition was a trial to you, but you didn't scorn or despise me, but you received me as an angel of God, as Christ Jesus. It's exactly the exact same language in which when someone is sick, you receive them as if the person is Jesus himself. And Jesus teaches this in Matthew 25. And uh, uh, then the righteous will answer him, Lord, when did we see you hungry and feed you, or thirsty and give you drink? When did we see you a stranger and welcome you, or naked and clothe you? When did we see you sick or in prison and visit you? And the king will answer them, truly, I say to you, as you did it to one of the least of these, my brothers, you did it to me. And what Christians have done from very early on, they began to reflect on this reality. And in ancient times, to be sick meant that you were being judged. You had done something wrong. God was punishing you for something. And to be sick was a stigma and a demonstration that and it created people did not feel an allegiance to you when you were sick because you had done something wrong. So why should we care for you? Why is there an obligation for us to surround you? And what Jesus is teaching, it completely throws this on its head. It throws it on its head because now, not is God punishing you for being sick, God himself, in the Son of God, is embedded within the sick person. And there was a realization that there was not just a dignifying of the sick, but a realization that there was almost a divinization of the sick person, that God himself was with the sick person. And when you're in the presence of the sick person, you are in the presence of God. It totally undermines or reverses what the meaning of the relationship. And the Benedictine monks, who were some of the early Hippocratic physicians and practitioners, they took this absolutely literally. Within the rule of Saint Benedict, for example, when a sick person was brought to the monastery, and this is in the rule of Saint Benedict, when a sick person was brought to the monastery, all the monks would come out to the sick person, led by the abbot, who was the leader of the monastery. And the entire community, and this is kind of instructed within the rule of Saint Benedict, would get down and bow before the sick person. They would even put their faces down on the ground as if the patient was Jesus. And they took this very literally, that to care for the sick, they said, is above all else the most important. And they realized, well, it's kind of like in the Christian tradition, the receiving of the Eucharist. The body and the bread is an emblem of the body of Christ, and to receive it in faith is to receive Christ. In a similar way, the patient is a sacramental of Jesus, and to care for them not just to dignify them as a person, but to dignify them as Christ himself. And it's a total heart transformation when you begin to realize that's what's going on from a theological perspective whenever the patient and clinician are together. We can illustrate it this way. Oftentimes when we think of the patient-clinician relationship, we think, well, it's a human relationship. And it's an important one, but it's a human relationship. But within the Christian tradition, there's been this realization that the patient, as I've been just talking about, is a representative of the suffering Christ. They are a patient, they are a sufferer, and their suffering is tied or connected to the suffering of Christ. And so whenever the clinician sees the patient, they are to see the suffering Christ. And and honor them with, with a kind of worship. It's not just treating them as a whole person, it's treating them as God himself has come. And in the same way, the clinician is a representative of the resurrected Christ. The healing powers of the resurrected Lord flow in and through medicine, and in and through the clinician. And a lot of times patients tend to almost look at the doctor sometimes with this kind of honor, as if the doctor is almost like a god. And of course, doctors can take that energy and totally distort it. Whereas truly what a doctor is supposed to do is say, it's not me. It's God is the true healer. I'm just a jar of clay in which God is using to bring healing. And they point beyond themselves. They don't take any of the honor. They point to God, who alone is the true healer, in which the patient is experiencing not the healing and saving grace of God through the physician. It's really God himself, who is invisible, being mediated through the physician. And so this patient-clinician relationship, it's not just a human relationship. In the mystery of God, it is the suffering Messiah meeting the resurrected, meeting the resurrected healing power of God, of new life. And in that patient-clinician relationship, it is a special relationship, in which we're seeing all of the impersonal forces distorting it and undermining it. And I would suggest to you that when we are thinking about the patient-clinician relationship, we retain the language around hospitality, but we also call upon the institutions and the culture in which medicine and caregiving is being practiced, and we need to call upon it to protect hospitality and compassion as the central motivation in the care of the sick, where we need science, we need good science, we need money to make this happen, and we need organizational factors and law and so on. All of these things are important, but they can't eclipse hospitality and compassion, and that's where if we hold on to this, we can transition from the hostility that is kind of surrounding the patient-clinician relationship towards something that is much more hospitable. And I'm sure that triggers some thoughts, but I'll stop there.
Thank you so much, Michael. Thank you so much, Tracy, for those two really wonderful presentations. Please continue to put your comments and questions in the chat, and we will have an opportunity to come back to our presenters, because certainly a lot of thoughts. So we will turn to our final presenter, Dr. Presley. Please take it away.
Thank you. Really do appreciate what Michael and Tracy were saying. There's a couple of times when Michael was speaking, I wanted to say amen or clap my hands. But the patient as this incarnational sacramental moment is just absolutely brilliant. Want to talk about pediatric mind, body, spirit medicine. Kind of from Newark to Chernobyl back to Chicago. And want to talk about children and spirituality in a way that kind of shifts the focus or our understanding of spirituality. I think that when we think about spirituality and faith, we think of something that is a resource inside the person that helps them to overcome the challenge. But with children and spirituality, they're much more embedded in their body and in their community. So if a child has a major medical illness or has cancer, they can't trust their body. There is guilt, there's shame. They want to disassociate themselves from their body. And once they do that, you know, that's where spirituality begins, is in the body. So our whole understanding of the role of faith has to, or spirituality has to shift when we think about the spirituality of children. I want to make three other comments about spirituality in children before I begin my presentation. One, or next issue, children are very much embedded in their community. That means that even if you take a child to church and the family have rituals of faith and grace and forgiveness, that child's faith will be determined by the community where they live. So the likelihood of their becoming a drug addict, going to jail, drop out of school, early pregnancy, will not be determined by what happens in the church, but will be determined by the community, and they will have the same rates or quality of life as their community. So as I'm talking about faith, some extent following the tradition of Frantz Fanon, understanding what is happening inside the community, what the values, sense of hope, faith, all of those things, we have to be able to interpret and uncover that. With that said, some of the time that it may not be a good analogy. The way with cancer, where the body is attacking itself, spirituality may also do the same thing. That if the child understands faith to be this feeling of security and safety and connection, they may not have access to any of that, or for them, all of this is hypocrisy and a fraud because they're not able to experience any of those things that you talk about. So if the foundational level of faith is that assumption of faith and security, and they don't experience that, or their parents are becoming overwhelmed, an early faith statement means that we have the faith of our parents, and the parents are overwhelmed. If a child has a major illness, their family is overwhelmed by 8 to 12 different systems, professionals, and the family's frustration at the cost. And usually one parent does more management than the other. So there's major family disruption, if not divorce. So trying to understand when we're talking about major illness and all of the family, cultural, economic factors that shape that is critical. One other thing, I'm going to move back and forth between my work in Chernobyl, Chicago, other places. I really do enjoy doing international health projects because there's always a kind of cross-fertilization. That when I'm working in Chernobyl, for instance, I had to get clear what the principles or assumptions about health and care, and then almost use those other places almost as a lab where my ideas are being refined. And sometimes there's critical learnings that I bring back that I'm trying within communities here. The subjects that I'm going to try to bring together for my presentation, a brief presentation, I'm trying to bring together learning from pediatric psychological oncology, thyroid cancer and abnormalities, trauma that is individual, collective, and intergenerational. Beginning early on, I'm going to talk about technological disasters such as Chernobyl, poverty, and racism. A technological disaster is any event that increases human suffering and activities, and unlike tsunamis, which would be a natural disaster, technological disasters are anything that are created by human beings, like poverty or racism. After my brief summary, I'm going to try to suggest strategies that have proven to be effective with children who've experienced technological disaster. My thesis builds on the work of Carl Bell, a Black psychiatrist who connected health issues with Blacks in the United States with other places in the African diaspora, like the Caribbean, South Africa, and other African populations. I add that to the work of James Garbarino, who compared Black urban populations in the United States to Brazil, Palestine, Sudan, and a number of third world slums. Much of this political and social approach to health is also indebted to the work of Frantz Fanon, who made strong connections between individual health and political systems and processes. And I'm also including, ma'am, that I love very much, Chester Pierce, who was the first president of the National Association of Black Psychiatrists. My research points to the implications of collective disasters and trauma for childhood development, health, and spirituality. My presentation argues that urban poverty poses long-term health risks for children comparable to those seen after Chernobyl. The health problems that resulted in this nuclear disaster are not dissimilar for those children who are living in areas of chronic stress, whether that is Chicago, Atlanta, Detroit, Gary, Indiana, or Philadelphia, or other communities where there's high levels of gun violence, structural violence like poor housing, inadequate schools, and substandard medical facilities. For poor children, technological, economic, and medical crisis means that the health challenges are not substantially different in Detroit than they are in Nigeria, the Gaza Strip, Soweto, that the children educationally and in other ways look, the similarities between Nigeria, Soweto, and South Central LA are, for me, just frightening. I'm not suggesting that any of this is new information. If anything, I'm sort of ringing the bell because at times it feels as though that we've become too comfortable knowing that poor urban children in the United States have similar health outcomes as those living in the worst slums globally. The changes that are needed require that we are as concerned about children in the Congo, Liberia, and those living in the Gaza Strip as those children who are in Newark. Most of you are familiar with the ACE test, Adverse Childhood Experience, which has been well researched and used to measure or to look at the connection between childhood experience and medical and emotional problems. It is interesting for me that there is no item on the ACE that asks questions about what is happening in the community. ACE asks the question if a parent has a mental disorder or if there is domestic violence, but it doesn't ask if a child has seen a dead body or has seen someone assaulted on their way to school. How bad is it for children living in poverty in the United States? To try to answer this, for about 10 years, I was a psychologist investigating the relationship between thyroid cancer, depression, and low levels of radiation. I was invited to serve as the lead psychologist for the Chernobyl Childhood Illness Project. When I was first asked, I paused for a moment, wondering how much I knew about technological disasters or radiation. And as I thought about the issues, the technological issues of racism and poverty, which are technological disasters, I assumed that there may be some insights that I could bring from the United States to there. I also assumed that if I could help Black children in DC learn to be healthy, then maybe Kev and Moscow weren't too far off. For our project, which was funded by USAID the World Health Organization, and the country of the Ukraine, there were overwhelming similarities between the toxic effects of low levels of radiation and the interacting effects of racism and poverty. We assessed approximately 120,000 children living in the area near Chernobyl for thyroid disorders, depression, and trauma. For our psychological evaluations, we used earlier versions of the MMPI, the depression inventory, the house person tree, and we were given complete access to all of their medical and school records or any community groups that they were a part of. To try to understand the impact of poverty and racism, just want to give you a kind of graphic reminder of Chernobyl and the impact there. And it may feel like an overstatement to compare Chernobyl with the US, but I think the case could be made. The Chernobyl nuclear disaster took place in 1986. The radiation that was released from Chernobyl was 400 times greater than the nuclear bombs that were used in Hiroshima and Nagasaki. Most of the radiation fell in Belarus and Russia. A smaller amount was in the Ukraine, but it was still significant. The fire was so intense that it took over 1 million workers, called liquidators, who were assigned to containment, decontamination, and building a sarcophagus over the reactor. The project where I was lead psychologist was examining the human and medical consequence of disaster by examining the relationship of depression, trauma, and the correlation. We could never prove anything that was causal, but how much covariation was there between living with radiation and cancer, and what was the role of depression and trauma in increasing the likelihood that the body's that the body's immune system dropped. The initial studies found that there was 100 times increase in the overall rate of thyroid cancer in the immediate areas around Chernobyl, which included Belarus, Russia, and the Ukraine. Most of the cases, it is argued, was a result of children drinking milk contaminated with radioactive iodine. There isn't enough time to go through the woods to talk about the specifics of some of the details, but just want to give you a kind of broad stroke kind of summary. We discovered that children living in a home where the mother was abused, where there was domestic violence, those children's rate of cancer co-varied at a higher rate than children who were in a home where there was no domestic violence. We discovered that children whose sense of trauma was the highest, there was also a strong covariation. And assuming that cancer is so complex, there's 60, 90 things, but this population kind of stood out. And the third population that stood out was women, young women who lived in communities where they were very unsafe and there was high rates of sexual violence. Now, nothing is causal. Couldn't go before the AMA or a court to say that anything was causal. But as we spent months going over the material, it seemed as though that people's material world, what we know from the ACE scores, what we know from Fernot and other people and social psychology, is that all of these things were very much connected. And we saw this initially in thyroid. And the thyroid is this interesting gland where people who live with a lot of stress are more likely to have thyroid disorder, and thyroid disorders usually open up the door for a lot of other things. So if you see trauma, thyroid abnormalities, trying to understand sort of which one was more causal was a significant challenge. Do want to say as another side comment that in one school where we did our initial evaluation of 465 children, 465 had abnormal thyroids. So to have an abnormal thyroid, the thyroid is this incredible gland that it's incredibly powerful. It's a small gland at the front of the throat, just below the voice box. But it affects almost every tissue and organ system in the body. It affects metabolism, how we use energy, body temperature, heat production of the body, heart rate, cardiovascular system, brain, nervous systems, growth, development, digestive tract, breathing, respiratory, weight regulation. It is just this phenomenal thing. And I think my contention is that because it doesn't have the kind of widespread kind of screening that we did, and particularly with poor children, I think that the connection between thyroid, difficulty learning, the children at the one school would come to school, they would be anxious, they would be depressed, easily shamed, memory was affected, they were very shy, easily insulted. So and in my clinical practice now, for any child that comes see me, in my clinical office, one of the things that I ask first is, have you had the child's thyroid checked? Of people within mental institutions inside the United States, 30 to 35% have abnormal thyroids. So, but all of this you kind of know in terms of Bessel van der Kolk's work, in terms of the body keeps score and the epigenetic process that takes place. Let me just suggest 5 or 6 things that I do when I'm working with these children and their communities. One other thing about their situation of being affected by Chernobyl, illness, radiation, is that they felt as though they were outside of the community. The collective trauma fragmented the community. There was a disruption in systems, and the children for the country were the embodiment of everything that was wrong, much like I think within the United States, when we see poor children who are living on the street, we are as much enraged by them as we feel sympathetic. So one of the things that we started doing early on was giving the children a cognitive map of what was happening in their world, helping them understand the intergenerational process that created them in this situation. So it was important for them to know all of the genocidal stuff that happened in the Ukraine during the reign of Stalin. What happened when the Germans built 400 concentration camps just in the Ukraine alone. But their understanding what was happening within their body, what was happening in the community, what was happening with their parents was very important to their being able to understand what was going on. And my feeling was that once a child reached the age of 5, you could start communicating to them that kind of cognitive map. When I worked with children, I assumed that there was a major shift in their movement towards growth once we had ethical discussions, which for me was pivotal, because ethical discussions pointed to their responsibility to care for others and the way that they receive people's care for them. But to say that they've got ethical responsibility now means that they're no longer just victims, but they have a sense of agency. It also reestablishes their attachment to the world around them, and with an assumption that they have a responsibility to be even more ethical than the folks around them. So whether they're sharing their lunch with another kid, what we know from grief and bereavement studies is that where there has been caring relationships, a kind of almost hospitality that Michael was talking about, and children learning that was almost foundational to some of the other kinds of growth and other issues that were needed. Two more things briefly. At the schools that I work with in high conflict areas, one of the things I would suggest is that traditional instructional learning could no longer be more than 50% of the day or the week. That you have to help children to become embodied. You'd have to work on mirror neurons where empathy, learning, all of those things take place, which allowed kids to be adventurous, to rediscover themselves. And the rest of the time, it was crucial to do music and arts and other things that were quite creative. And lastly, just want to say the care that you give for the caregivers. During my first couple of weeks there, I was pretty much an idiot. And I gave the psychologist a thing of saying, before we do anything else, we have to be able to determine the mortality rate of sort of what we're looking at in this particular area. And I made a really stupid joke. I said, anybody who doesn't have the work done by the morning, you got to go live in Poland. The next day, nobody turned in their work. They said, you don't know that much. Poland's a much better place. We're not turning in anything else for you. But then as we talked, it became clear when I asked, all of the caregivers also lived in the most contaminated areas. So as we were thinking about the needs of these children, they're also thinking about their own children and what's happening in their families. And in the more challenged urban areas in the United States, the caregivers either live in the community or are closely attached to it. And if you don't do that, their primary combined to secondary trauma, so that you've got complex trauma going on, so that if you're not able to do more to rejuvenate the life issues of people who are the caregivers, caring for children in terms of their mind, body, spirit connections is close to an impossibility. Thank you.
Thank you so much, Dr. Presley. Thank you so much. And once again, thanks to all our presenters. I will pass it over to Dr. Saida, who will now moderate the Q&A.
Thank you so much, Kenneth. It was a wonderful presentations, eye-opening presentations by all three of our presenters. And I do see many responses and questions came from our audience. Let me start with the questions. First, I believe it was from Tracy's Dr. Tracy Bimoni. So yeah, thanks again for your wonderful presentation. It was so resourceful. A question came from Pete. I think this might be answered later by other speakers, but a question that I currently have is, how can we build systems of care that integrate spirituality when there is such a diversity of spiritual beliefs especially the ranges of religious affiliations in cities like New York, or the potential discordance of spiritual believing between the patients and the providers. Maybe uh, Tracy, if you try to get some response on that.
Sure, it's a tough question for sure. And there are many layers, I think. I mean, one is the first taking the approach of spiritual care is always, what we call patient-centered or person-centered. So it's always honoring and of where that person is, and that, that can be, the variety of different sort of faith traditions or spiritual backgrounds that individual has, and it's not dependent upon, so for example, there being concordance between me and that person, or the clinician and that person. It's really, I think that's an important, it seems very, pretty straightforward that it should be that way, but I think it's important to really accentuate that, because even if there is concordance, there are ways in which we have to be very careful, particularly with the sort of the power differential that's present as far as the resources that the clinician has versus the patient, the authority that they have. So no matter what, even if there's concordance, there has to be kind of a way in which you're very much focused on not, because not what I need is, where based on where I come from or the clinician comes from, but really where that person is. So I think first and foremost, if we're going to start with the patient clinician interaction, it's being centered. Now, that doesn't mean that as clinicians, no matter what faith tradition we come from, we of course are going to draw upon and should honor the ways in which our own spirituality can uphold our ability to care for patients. So, as when Michael was describing sort of the clinician even kind of seeing the patient as in some ways sort of dignified in such a way that's even divine in the mind of but even in doing that, if I see Christ in my patient, I can still, that patient can be, doesn't matter. They could be an atheist. They could be a very different religious tradition. Anyways, and my care for them should honor who they are and their dignity, no matter what faith tradition they happen to have. So just to name that first. And then, I think it also raises the importance of there being, based on that framework of patient-centeredness, then people like chaplains or other people who have a degree of connection to and a way of having language with the varieties of spiritual traditions that a particular culture might have, so that care is built around the various populations of people that happen to be cared for at a particular institution. So I think that's a place where in building spiritual care, there can be a lot more work done, as building bridges with faith communities in the area so that they understand, whether it's that you get connected with a faith community leader if a patient wants that or a family wants that, and having those connections already, or embedded within a spiritual care program, or as you're building spiritual care within an institution, actually, asking faith communities to provide input on what that might look like. And then that way, if you're, because it's linked with the community and with the varieties of faith traditions that are represented within that community, I think it also can be more sensitive to the needs of various people from various faith traditions that are represented there. So those are like two major ways that there are. I think there are many others to build a system that can care for people from many different kind of spiritual backgrounds, faith traditions, etc. But those are two important ones: patient-centeredness and connecting with the with those within the community representative of those various faith traditions.
Great, thank you, Tracy. I believe this is, this answers this question very, very effectively. And also, in my belief, is the religion is with from every religion's perspective is how we look at our creator and how we do worship our creator. That's the difference. But practicing goodness and practicing good behavior with people to patient, or sick people, or healthy people, good behavioral characters, and ethics are part of all religion. All religion supports that. Yeah, yeah. Okay, thanks. So there is another question for you from Oil. Thanks, Professor Tracy. If you have time, have a couple of lectures, or maybe those are some of the things if you can describe a little bit. Does spirituality impact mental health? Number two, from the evidence you shared, what is the strongest evidence linking spirituality to improve health outcome in honor in cancer or palliative care? And I'm going 4 questions, so maybe you might find connections with each other. What validated tools exist as assisting a patient's spiritual need during treatment? And number 4, how does better quality of life assist in the data you presented? I can repeat if you ask any question.
That's a lot. There's a lot there. And I'd, love to pull in our other panelists as well. Like one just picking up on the first one about the role of spirituality and mental health. So there is I didn't spend a lot of time on that evidence, but definitely very strong evidence regarding being very intertwined with faith communities, highly involved in a faith community, and less suicide. A very strong relationship there. A very strong relationship with, and actually, there's a recent meta-analysis publication in JAMA Psychiatry regarding being highly involved in faith communities and other spiritual constructs, and less substance use disorders, as well as better substance use recovery. So all of those are, key pieces of evidence. I just want to highlight what, Dr. Presley was noting about how I really like, I guess maybe partly because I'm an oncologist, but I love the analogy of how, of cancer, and how, spirituality can kind of be like our body that functions well, but there can also be dysfunction. And so I want to name that these meta-analyses are broad swaths of studies that on average find these associations. And but there are ways in which, when there is breakdown within communities, and certainly I think breakdown within the kind of spiritual fabric of that community, which can happen because of, everything from the injustice of poverty or racism, or even disasters, it's kind of like the flip side of those findings, where it can result in definitely poor mental health outcomes being one of those, and as well as other disorders. So I'll just focus on that one just because there's so much there, but we could speak for hours and hours. I hope.
Okay, I'm coming to some other questions. Also, there is some more questions for Michael from Will. I'm gonna come into that. There is another question. Another is from Joel. This was a very highlighting. Thanks, Tracy and Michael. And This is another from Vivian, really defining presentation. Thank you from Liz, amazing perspective for both of you. Oscar, thank you for the wonderful presentation. Liz, from amazing perspective for both. Oscar, thanks to both. Okay. Um, Yamisi, wow, thanks to our presenters for for clear connection between spirituality and healing and the physical body. From Patrick, the patient clinch. This is a very important questions. Maybe all three of you can um, find some connections. The patient clinician model seems to be emphasizing shared decision making. The patient autonomy rooted in values like empathy, etc. In real clinical setting where clinicians may only have 10 to 15 minutes with 16 patients for an internal medicine physician in academic medicine with a team that may also have interns and residents. How can this medical realistically be implanted without compromising either efficacy of the doctor and the patient's voice? So maybe this is something, do you want to start? Who can answer with, do you think maybe,
I'll just start.
okay.
Yeah, it's a great question, and there's no simple answer to this. Without compromising efficiency. Well, efficiency is part of the issue, and how the whole system is being created and set up. So that's if efficiency efficiency is part of the metric that is coming out of bureaucracy and is coming out of the market forces. So that's why efficiency is there. And so part of the criticism is that it's shifting and changing the nature of what it means to care for the sick. That said, I think it is important to kind of realize when it comes to really receiving the patient, it's not just a physician as an internal, medical doctor, but it is an entire team, and working as a team is really quite critical and important. In some of our interactions, conversations with patients, it was the people cleaning the bathroom who have a more powerful effect on the patient than almost anyone else. So it's in other words, it's an entire team of people who are receiving, who have different roles and who have different amounts of time. And within the current system, an attending physician may only have 15 minutes. And that's a difficult way to care for people, and it's very difficult to sustain. The system is creating that. I'm not sure it's really the best approach. But that said, even going to the Christian, if I can go back to the Christian tradition, the demands on Jesus as a healer were immense, and many, many, many people, and so the drain on him, the amount of time he would have. So different people will require different amounts of time. But nevertheless, the model of hospitality can still inform, even if you have 15 minutes with someone, it can still inform what the outlook and the engagement of, let's say, a very busy physician.
Yeah, thank you.
And you can be with a physician who is just running through a checklist, and you can be with a physician who is really attuned to the patient. It's hard to, and I think if you've ever been in that situation, you know what the difference is.
Yeah, that is true.
Yep.
Thank you. So another questions from so from Patrick, the same person had a few more that the clinician model account for the patients who face barriers such as low health literacy, language difference in socioeconomic disadvantage or difference in religion beliefs different from that is the clinician. Does this model risk uh, some what do you think with the very I believe that's already have been some answer been done by Tracy, so I'm not gonna go too much, but if you like to mention anything like who already have some resource there or education or have some religion belief as the clinician offering care. So there it does like if there the patients and a clinician has any difference of religious or beliefs or does it help or hurt? I believe it has been answered. So let me go to the next question from Oscar. When we look at the work of the Good Samaritan as is described in Luke 10:25-37, do we find that level of compassion shows by our medical professionals today? If yes, what can be done to expand this practice? And if no, what can we do to build this culture in medical arena for Drs. Tracy and Michael, for both of you?
I was going to defer to Michael, but
Um, so yeah, there are different levels of compassion, and sometimes I think probably the simplest answer is that doctors, nurses get wear themselves out and burn out. It's a kind of a natural progression. They get tired. They can start to lose their own sense of humanity. And the more dehumanizing a medical system is, the more quickly the caregivers will begin to lose themselves. So I think there's a lot of people know that and have experienced that. And I think there is need for rest. There is need for to going back to one's deepest traditions, to draw and remember why you're a caregiver, what it means to have compassion, and tapping into those deep resources. So I as a pastor, I invite doctors and nurses who are Christian to return to the models of Jesus, to read his words, and to pray and ask for the Holy Spirit to give them strength so that they can have that compassion on a day-to-day basis. And they need to kind of continue with practices to strengthen and maintain their posture of compassion, because the secular system tends to be very dehumanizing and undermining of compassion, and because of the call for efficiency, for example. And so there need to be those ongoing resources to resist those hostile forces and to continue to practice into hospitality. So and I think, for those who are coming from different traditions, they're going to need to find spiritual practices that help tap them back into their core resources of compassion. All of the major traditions have this. And unfortunately, one of the issues is that religion of various traditions isn't really allowed within much of medicine. It's kind of looked down upon, and I think that's part of the problem. So we talk about the language of socialization. Medical caregivers are socialized to disconnect themselves from their religious traditions and be these neutral agents of care. And that's actually part of, we've argued for example, in our book, that that's actually part of the central problem. And that doctors and nurses and others need to tap into their traditions, not to proselytize. So don't misunderstand. It's not to proselytize their patients, but it's to draw from their own traditions in order to be the kinds of caregivers that all of our different traditions call us to be. Anyway, that's just kind of a quick response to an important question.
Thank you. So next question to Professor Arthur from Will. Your work connection to Chernobyl is one of the most fascinating and distinctive aspects of our scholarship. You use the Chernobyl disaster as a case study in trauma. Chernobyl, meaning that meaning making and spiritual reliances, especially in communities facing long-term psychological and existential disruption. Questions. Chernobyl created a trauma that was not always visible. Radiation, uncertainty, stigma. How does invisible trauma differ from acute trauma in its spiritual and psychological impact? Yeah, this is very important question. Some trauma
Okay,
you cannot see.
could you do the last sentence once more?
Yeah, sure. So the question is, Chernobyl created a trauma that was not always visible. Radiation, uncertainty, stigma. How does invisible trauma differ from acute trauma in its spiritual and psychological impact?
Not. It sounds like an important question, and it may have to come back to me as I think about it. I do want to go back to a previous question about mental health and faith. This, I'm really in love with the study that Tracy did. And a couple of the people who were part of that study, Gary Gunderson, Ken Pargamont, there's a lot of people there that if you got a copy of the study and you read, many of them in enormous ways kind of lay out the way at which faith can make a major difference in terms of health. You were asking about the difference between visible and invisible trauma. Is that?
Yeah, that is one of the questions, but he has a couple more. I can.
Okay. Yeah, I think that with the people that I work with, there is always a kind of, in addition to the pain, there's always a kind of moral injury that was part of that. People felt as though that if the doctors would have been better, if the hospital would have taken my mom in, if systems had not been so prejudicial, I think that the ethical component that makes it most traumatic is the place that we don't always see. And it's important to kind of listen for that. And
Mhm.
I'm sorry, no, please go ahead, because you've
No,
got
there is
questions
couple
and
more
a little
questions,
bit
so
of, yeah.
maybe if you can combine together. So what parallel do you see between Chernobyl and modern form of slow trauma, such as for a cancer patient or systemic injustice? So does trauma, mental health, as in the case of children, impact their resilience to disease? That's already, yeah, you mentioned.
Another question at which I think I'm going to give a bad answer. When I work with children in disaster zones or in conflict zones where there's shooting or a number of other countries, increasingly, I don't know what resilience is. You know, if you've got a child who's got anhedonia, which is the complete inability to experience anything pleasurable, if they are, as a result of that, if they're neurodivergent and it feels like they're not able to control their mind or their body, they're not able to have meaningful connection. So depending on where they are on the continuum, I really wrestle with it. So some of the kids that I work with, it's kind of like almost saying, if you showed up today, you're resilient. Don't have to do anything more than that. And it's almost as if the community has to be resilient for the child in many ways. So I think of faith in a real way that is communal. And the question is whether the recovery and the movement is something that we expect to see in the child, or that is something at which you're working with the parents and the school system and the places that I work. You know, usually if you don't get 12 different systems to all be resilient in the face of the trauma, but I don't think of something that is located inside the child. And kind of what Michael was saying, we talked about the janitor. You know, when I go see my doctor, the doctor asks me 100 questions. Am I still swimming? Or just the doctor raising the faith question means a lot. And so much of the question presupposes that the healing system is the hospital as opposed to something that is broader. So nurses, chaplains, there is a range of people who patients may see as part of that system, where I think just a 90-second conversation about how's your faith, who's supporting you, makes a huge amount of difference. But I think when you ask about invisible, you're talking about what we call microaggressions, chronic, you know, being marginal communities and those things where it is so systemic that it's not clear to identify, you know, who's doing the injury and who's being receiving of that. And I think it is the responsibility of the community to be the interpreter, to be the place of faith, to sort of hear what's going on underneath the system. We really have to be far better detectives to hear sort of what's not being said in between the gaps.
Thank
So, but plug once, if you can get Tracy to send you a copy of her study, please do it.
Yeah, no, thank you so much. Yeah, thanks for um, answering these questions. There are a few comments and questions from Susan. Thank you. From Liz, the impact of technical disasters is so sad. This coordination between the physical and emotional triggers is eye-opening. Thanks, Dr. Presley. Joel, thank you, Dr. Presley. Your presentation was not only informative but heartfelt. Oscar, Dr. Presley, thank you for very informative presentation. The impact of disaster in children is very critical, and your work is meaningful in shaping their being. Thanks again. From Nana, thank you for all the very informative presentations. And I believe I left a couple more questions. If you have time, I think there is a big question from all. To thanks, Dr. Michael, for your important work in the book with Tracy. The questions are: what could you say for our forms of hostility towards spirituality and most embedded in medical training today? And maybe I'll go for a couple more questions. How can healthcare institutions shift from a culture of hostility to one of the hospitality? And you talked about forces. What of these four forces shaping American hospital care, those three: scientific, market, legal, and hospitality, is most needed in spiritual renewal. So let's go for
Sure.
discussions and
Yeah.
hear some comments too.
Just again, in brief, the three impersonal social forces, the technology, market forces, and bureaucracy, they're all interlinked and they track together. You can't, they all depend on one another. Um, and the, uh, the one of the issues is that institutions carry these social forces. So this is kind of analysis by Max Weber, if you're familiar with the famous sociologist of religion, Max Weber, who has written about bureaucracy. You could find PDFs of his analysis of, but his work, essentially shows that that these forms of these social forces are interlinked and they lead towards more impersonal experiences for people. Bureaucracy, by definition, is deeply impersonal. Um, and what it leads for many, many patients, they experience their care in a very impersonal way. And they don't feel seen as a whole person. They're primarily being focused uh, on their physical body and the medical condition. They're seen as a case. They're seen as a disease. They're not seen. They're not seen as a person. And these impersonal social forces are creating those kinds of are interacting with one another and creating those kind of conditions. Yeah, go ahead, Arthur,
Yeah,
please.
oh, I'm sorry. Just want to add something. Insurance companies, they've known since the 50s and the 60s that if people receive spiritual care, they're out of the hospital 30% sooner, they need less medication, they're making fewer demands on the staff. Everything about how people use the system, how soon they get out of it, all of that is greatly affected by the kind of spiritual care that they get. When insurance companies were presented the information, earlier studies by John Farrell in Indiana, Clinton McNair in the Veterans Hospital, we see substantial medical gains from, and we've known that. And when insurance companies were asked to collaborate with them in terms of the spiritual care, they have adamantly refused. So if we're going to be angry, somebody needs to be out in front of some of these insurance companies burning tires or something. But
Yeah. Maybe in future, like Michael or other religious people come together and prepare some kind of a note or page and figure out which is the faith-based. Like your medicine is always helpful, but keeping faith and thinking of positiveness. Faith brings a positiveness, brings your emotion strong, and immune system action more, activate more immune system, because the positiveness takes you to the positive healing process. So if there is a permission, like based on the patient's faith, if you can at least give a handout, just bring your faith strong, may God help you, something like that. May bring some kind of a hope to the patient. That's my opinion. Yeah. Now, thanks to everybody, and we do have lots of other questions, but with the time being short, so I believe we can end the questions answer time here. Going back to Uh,
Yes, so thank you so much. Let's give a hand of appreciation to all our presenters again. Thank you for your time and for your expertise, for the wonderful conversation. Thank you, Dr. Saida, for moderating that Q&A. I'll hand it over now to Dr. Gloria to close up our time today.
She might have stepped aside. I think Dr. Kenneth is
Okay,
back.
so Dr. Gloria might have stepped aside. So anyway, let me just once again thank everybody, and this program continues. We are now this is the fourth session. So next week we will have another session, and it will be on lifestyle medicine and integrative health, and we hope that you can join us again for that conversation. We believe it will also be very informative, and we'll look forward to our presenters next week. And for those who are interested in doing projects, again, contact any of us, and we will work with you to figure out what projects you might work on for the final. So let us thank everybody, and I hope you have a wonderful weekend, and we'll see you next week.
Thank you.
thank you.
Thank you.